Um, and so that's all fine. I kind of geographically limited myself. So when you think about where you're going to apply to medical school, think, try to think maybe more broadly than I did. I'm from Pennsylvania. I really wanted to stay close to home just because that's the kind of person I am. And I didn't get in the first time. And so you could imagine, I thought this was the only thing I was going to do with my life, and I didn't get in the first time. So that was pretty devastating. So life lesson number one, don't limit yourself. And what I tell my kids these days, if at first you don't succeed, try again. So of course I did. It really made me sort of reevaluate what my goals were and what I wanted to do. And I had a counselor in my life, like a college counselor, who said to me, what do you want to do? What are your goals? And at that point, I thought I was going to be a primary care physician. And she said to me, did you ever think of DO school? And I had absolutely no idea what a DO was. So I kind of explored that, talked to some people who were DOs, applied early decision to a DO school and got in. And so that's how my path started. And so I kind of knew early in my career path, kind of that I wanted those long-term relationships with patients because I knew I wanted to be a primary care doctor. Like I knew I wasn't going to be an emergency room physician or a surgeon. And so that's kind of where, I gravitated toward. But I accidentally found rheumatology in my third year of medical school. And so what happened was I was doing an allergy elective, and the allergist only worked 2 days a week. And he said to me, let's walk around and see what else you can do the other 3 days. We have a rheumatology clinic here and a pulmonary clinic. And I said, well, I know what a pulmonologist does, but I have no idea what a rheumatologist does. And so he walked me over there and said, hey, can this student spend 3 days a week with you? And they said, sure. And the rest is history. I just absolutely fell in love with it. And so, it's one of those things where if you're never exposed to it, you might not know what you like. And so it's interesting, the American College of Rheumatology is very well aware of this, and they have a lot of outreach for medical students and residents to try to get them to understand what rheumatology is and that it might be a career for them. And so if you're ever interested, you should check out their website, rheumatology.org. They have lots of information on there about career paths and just information about what it's like to be a rheumatologist or what it's like to be a patient. So it's a nice website. So what else is it about rheumatology that I love and why I'm in this job? As I mentioned to you, there are long-term relationships with patients. And so just anecdotally, I will tell you, I lived and worked in New Hampshire for 12 years before I moved here last year. I've only been here a year. And so I had, a well-established panel of patients that I knew really, really well. And it was really hard walking away from them. I had 800 patients. I knew their families. I knew their ups and downs. They knew mine. And some of them I actually still keep in touch with because we were more like friends than doctor-patient relationship. And so that, if that's the kind of thing you're looking for in your career, rheumatology is a wonderful career to think about, because some of these patients will see their rheumatologist more than they see their primary care doctor. You almost become like their primary care doctor because they have such complex disease. You're the only one that kind of understands what's going on with them, or at least can help be the quarterback to explain and coordinate all of their care with everybody else. And so that relationship really can be a very fulfilling one. And so I'm sort of in the process of rebuilding a practice here, which is slow and takes a lot of time, but it's okay. There are incredibly interesting cases. Today was no exception. I had an amazing clinic today, and I don't have time to go into all of it, but just know that every single patient every single day is completely different in rheumatology. There are no 2 days that are alike. There are amazing research opportunities. So there are new treatments that are coming out all the time. We are in sort of a golden age for rheumatology. in that we have new treatments for diseases like rheumatoid arthritis, lupus, maybe even scleroderma, which is hard to believe because there have been decades and decades that have gone by with no treatment for those patients. And now we're actually having treatments for them that are making an impact on their lives. And so that's exciting to be a part of, and exciting to be able to offer people. And so it's just an exciting time to be in rheumatology. For years before like the TNF inhibitors came around, like Enbrel was the first one, we gave patients with rheumatoid arthritis gold shots and aspirin. That's all we had. I mean, that's pretty pathetic. So we've come a long way in the last 20 years. And I think we're going to go a long way in the next 20 years. I had a patient today ask me, do you think there's going to be a cure for rheumatoid arthritis in our lifetimes? And I was kind of shocked by the question. I was totally taken aback by it. And I sat there and I thought, there might be. There might be. I don't know. I don't have a crystal ball, but it's exciting to think about. I think that we'll probably get closer to personalized medicine for these patients because we're getting closer and closer every year. So again, lots to offer patients, very exciting stuff. And finally, and this is really important to think about, work-life balance. I think rheumatology really does offer an opportunity to do something cognitively really interesting, but also a chance to walk away and have your life. And those things are important because you just need that. You need time for yourself. You need time for your family. You need time to have a life outside of work. And rheumatology is a really attractive option when it comes to that. And rheumatologists have been surveyed many, many times about this. This always comes up as an attractive part of rheumatology is work-life balance. There are very few emergencies in rheumatology. And in terms of call schedules, it's usually very light. As I said, we're mostly an outpatient specialty, so you're not having to run into the hospital for urgent issues. Other things to consider for this specialty, again, I mentioned this, outpatient versus inpatient medicine. This is where you have to kind of know yourself. You have to know your personality. You have to know like what you want your job to look like. Some people really want more of like shift type work. They want to go in, they want to do their job, and they want to come home. And some hospital-based jobs are more geared toward that. Outpatient medicine tends to be, like I said, more longitudinal. There tends to be this more long-term responsibility for patients and management, and really just depends on your own personality and kind of what jives with that. Are you more cognitive person or procedural person? And those two aren't mutually exclusive, but that's kind of how we think of it sometimes. So you may lean one way or the other. At least with rheumatology, you've got to be okay with some degree of uncertainty. So a lot of rheumatology is in this gray zone in the middle. I think you have this, time will tell, we're going to follow you and see what happens. Human beings, when they present in our clinics, don't read a medical textbook. So they show up with symptoms, and a lot of times it doesn't look like what we learned in medical school. It's not clear cut. They've got features of one disease, but it's overlapping with features of another disease, and the labs are a little bit ambiguous, and we're not quite sure what's going on. And so we have learned to kind of be okay with that. And we talk to patients about patterns of disease, and we talk to them about using medications to help with symptoms and following them over time and seeing how disease evolves or progresses, or frankly just goes away over time. And so you have to be okay with some degree of uncertainty in rheumatology. If you're like a black and white, I need an answer kind of person, rheumatology may make you very uncomfortable. And then finally, do you enjoy immunology? So rheumatology is really rooted in immunology. And so if you don't like to think about B cells and T cells and the complement system and macrophages and all these different things, you might not enjoy rheumatology. Once you choose a career in rheumatology, there are lots of things that you could consider. There's private practice, which has a lot of freedom, I think, associated with it, because depending on whether you own that practice or whether you are part of a group, a lot of times in private practice, you I hate this phrase, you eat what you kill. You know, you work as much as you want and you get paid as much as you work. And so there's flexibility in that, depending on what you want your salary to be. Some people want that and some people don't. If you choose an academic career, there are various different ways of going. You can be a clinician investigator. You can be a clinician educator. You can be a basic science researcher. There are people that are physicians that still do that these days. Those numbers are dwindling, but we need those people, frankly, particularly in rheumatology. And what we really need are those translational people who understand the bench and the bedside, the people who can take care of patients with rheumatoid arthritis, but also do the basic science research of understanding what's going on at a molecular level and really help us to find the next treatments or perhaps even the cure. I already told you about pediatric rheumatology and how desperate we are for pediatric rheumatologists. They're industry jobs. I don't know a whole lot about them, but they're out there. And I've had some colleagues leave academic medicine and go to industry. And then, you know, there's a rheumatology health professional track. So you could be a nurse practitioner or a physician assistant and work in rheumatology. And that is an incredibly rewarding career. And they are so helpful and so needed in this profession. They are part of our team. In our own clinic right now, we have one nurse practitioner and one physician assistant, and they are essential to what we do. And I wish I could convince more people to go into that because they are phenomenal. They do everything that we do as rheumatologists and are part of the care team for our patients. And so that can be a very rewarding career for people. And there's a whole arm of the American College of Rheumatology that's dedicated to rheumatology health professionals and helping to support them. And with a shortage of rheumatologists, I'm hoping that we can sort of recruit more people to be rheumatology health professionals to kind of help take care of our patients. Because the number of patients with autoimmune diseases is only going up. And our population is aging, which is causing more arthritis. So, you know, the shortage of rheumatologists over time is going to get worse. So we're looking to find creative ways to try to fill the holes and fill the gaps. So my job currently, just to give you an idea of like one person's academic job, my job at UNC is 60% clinical, which means I see patients 3 days a week. And so that's a breakdown. Every week is different, but I see my own patients. I do ultrasound. So you can use an ultrasound machine. You can put it on patients' joints to actually look for inflammation. So you can use that for diagnostic purposes, but you could also use it to see if they're responding to treatment. We can use it to guide injections. And so I do that once a week, half day a week, every week. I do a lot of teaching, and so I work with the fellows in their continuity clinic. That's a clinic they have every week taking care of their patients. We have an urgent clinic where we see patients that are really sick that need to be seen right away. And then that inpatient part that I mentioned is our consult service, and I work in that service 6 weeks a year. The rest of my time is spent on administrative work as the medical director of our clinic and in teaching. And I do a lot of ultrasound teaching. And really one of the most fun things that I'm currently doing is helping to build what are called multidisciplinary clinics. And these are clinics that are involving those other specialties that I mentioned earlier. To help take care of patients who have complex needs, who need to see more than just a rheumatologist, so that we can get them the care they need, like at the same time. So today, for instance, I was seeing patients at the same time as the kidney doctor. So me and the nephrologist walked into the room together and saw the patient together, or me and the dermatologist walked into the room together and saw the patient together. So we're doing that for certain populations of patients, and we're also doing that with some of the pulmonologists for patients that have lung disease. So that's actually very exciting. The patients love it. Takes a lot of back end work to build that and make it happen, but it's a lot of fun. And like I said, the patients love it. We learn from each other, which is fabulous. The learning never stops. I'll just tell you right now, I'm 15 years out and the learning never stops. And I hope it never does. It shouldn't. And so that is really probably one of the best parts of my job. So a typical day in my clinic, I'll see 10 to 15 patients. Like I said, I do ultrasound. I'm almost always with a learner. So that's either a medical student, a resident, or a fellow. And like I said, no 2 days are alike. And so this is what gets me out of bed in the morning. Like the patients are amazing. They need our help. There's a lot we have to offer them. And it's incredibly rewarding. And they're very grateful. So this is what gets me out of bed. Now, I think I'm going to switch gears. Yeah. So you can't, obviously this is supposed to be a shadowing experience. You're not in my clinic. I wanted to kind of run through a couple of things that patients that you might see in clinic with me, just to give you a flavor of what rheumatology looks like. Before I do that, I'll just stop really quick. Does anybody have questions for me right this moment? Okay. I will tell you that all the pictures I'm going to show you came from the American College of Rheumatology Image Bank. I didn't want to just randomly pull pictures off Google. So the American College of Rheumatology keeps a bank of pictures over the years of patients. They're all copyrighted. We're able to use them. And so that's what you're going to see. So these are pictures of patients with rheumatoid arthritis. And so when we see them in our clinic, I hope you can see my pointer. These top 2 pictures are patients with sort of acute disease who have swelling in their hand joints. I'm going to just point them out here. And then these other pictures are really more chronic disease, people who've had disease for years and years. And they'll have deformities of their fingers where you see they just don't straighten out all the way. This is called ulnar deviation here in this rightmost picture. So these are patients that have disease for decades. Gout we see very commonly. Gout is the most common inflammatory arthritis in the population. Here's the typical patient that we'd see is like a young male who's got acute inflammation in his toe joint. You can see redness down here in his toe. He's also got some inflammation in his ankle. Again, not uncommon to have it in 2 joints, but the toe is the most common. Gout can affect older adults though too. And this is a picture of an older female who's got osteoarthritis in her fingers, like this finger here. She's got what are called Heberden's nodes out here, which is osteoarthritis, but then she's got gout layered on top of it. That's all this red stuff. And this is just crystals and crystals and crystals, gout crystals, all swollen and on top of those osteoarthritic nodes in her fingers. And this, sorry, I hope this isn't too gross. This is a toe that's affected by gout. You could see how someone might think this is infection. It's all red and swollen. This is all gout material coming out of this person's toe. And so I have to tell you that one of the reasons I really love rheumatology is that the physical exam actually matters. Like you have to actually touch patients to understand what's going on with them. It's not just about lab tests, it's not just about imaging. You have to actually get a history and examine them. And so it's kind of old school, and that's what I love about it. That stuff actually matters. There's another type of crystal disease called pseudogout. This is a different type of crystal. So this gout that I showed you before, this is uric acid that's built up in the joints. This is a calcium crystal, and it's all deposited in this person's knee. This is a knee x-ray. And all this white stuff is calcium built up in the cartilage. This is really common in the population. Lupus, another very, very common disease we see, particularly around here. And these patients get terrible rashes. This is the malar rash or the butterfly rash that we see. They get photosensitivity. So this person went out in the sun, and where her shirt was, she's perfectly fine, but she's terribly burned in sun exposed areas. This is what's called Raynaud's phenomenon, where you have really poor blood flow and you see the fingers turn white. The rest of the fingers have good blood flow here. And this gentleman has what's called discoid lupus. This is a very scarring type of skin lesion with lupus. Psoriatic arthritis. So patients with psoriasis can get arthritis. And this hands here on the left, this person has a lot going on. He's got psoriasis in his skin with these red lesions here and here at the tips of his fingers. His nails are all involved. And then he's got fingers that are completely swollen. So like his left index finger is really swollen, say, compared to the right index finger. This is called dactylitis, which is also known as a sausage digit. This is very classic for psoriatic arthritis. And he's also got swelling like out at his what are called the DIP joints out here. This is all very classic for psoriatic. And those patients tend to get pitting in their nails. You see these little pits. These patients, when you see this, are at increased risk of getting psoriatic arthritis. I didn't have a picture of fibromyalgia because there isn't really much to show, but fibromyalgia is a really, really common pain condition, particularly in women. Its prevalence is around 2% in the population, and it's the most common cause of generalized musculoskeletal pain in women ages 20 to 55. It's got associated sleep problems, fatigue, cognitive complaints. So people will talk about being unable to kind of multitask, word finding difficulties. And really, there's no inflammation in this condition. It's a problem actually with central pain processing in the brain and spinal cord. It's fascinating. There's no test for it. People are working on it though. And so the way we diagnose it is really based on history and physical exam. If you ever hear someone say fibromyalgia isn't real, they're wrong. It is absolutely real. And when, you know, the analogy I give is when you tell me you have a headache, I have no test to prove you have a headache. Just like when people have fibromyalgia, there's no test, but I know they have it. And so it's very, very common in the population. Osteoarthritis, incredibly common, 40 million Americans at least with osteoarthritis. This is the wear and tear. That's a really bad way of putting it, but cartilage loss that occurs with aging gets accelerated for some reasons like trauma. This person has it in her fingers. You can see all these little nodes in her fingers. This is all bony hypertrophy from osteoarthritis. She's got in her feet with bunion deformities and hammer toes. These are all things we see. So you can imagine every day in clinic is different because, you know, we see a smattering of all of these conditions, and you have to know how to treat every single one of them. So another fascinating one, ankylosing spondylitis, where patients develop back pain at a really young age, usually in the teenage years. Usually it gets blamed on sports, but there's this recurring theme where back pain is worse in the morning and better as the day goes on. Usually it gets better with ibuprofen. If it's left untreated, the spine can actually fuse. This is a picture of the lumbar spine or the low back from the side, and it's fused all the way up and down. It's called bamboo spine. And if you look at it from the front, it has this flowing nature to it. There's a ligament that runs on each side of the lumbar spine and it becomes calcified and fused. They're called flowing osteophytes. These are classic pictures of ankylosing spondylitis. Thankfully, we have great treatments for this these days because this is what used to happen to people with ankylosing spondylitis. This was the natural history of it. So you see this gentleman in 1947 had a straight back. And then over time, he ended up like this in 1972, and he was just completely hunched over. They ended up with hip flexures, flexion contractures, so he wouldn't be able to stand up straight, not just because of his spine, but his hips would be stuck in flexion, and his knees would be stuck in flexion, so things just wouldn't move. Thankfully, we really don't see this anymore. If you do, it's because someone, you know, really was either misdiagnosed or not treated properly. Giant cell arteritis, this is one of the few emergencies in rheumatology. This is inflammation in what's called the temporal artery, and you can see this gentleman's temporal artery really well here on this left. It's kind of like curving up here. These people present with headaches and scalp tenderness, and they can have vision loss, and that's why it's an emergency. And they have a lot of inflammation in their blood vessels, and it only happens to people over the age of 50. Average age is 72. And the way we make a diagnosis is we biopsy this artery, and that's what you see on the right here. And we see a ton of inflammation, and we treat it with prednisone. And we have a high index of suspicion if the person is older and they have new headaches and their blood tests show inflammation. We don't even wait for the biopsy. We just put them on prednisone because we don't want them to go blind. And so we have newer medicines besides prednisone that we use for this these days, but prednisone is the go-to immediately if we suspect this disease in an older adult. Ankylosing, this is a complex multi-system disease that affects blood vessels, lungs, kidneys, skin. This woman has what's called a saddle nose deformity. So the cartilage in her nose was inflamed and has really destroyed the cartilage. So she has this sort of depression called a saddle nose deformity. There are these cavitating lung lesions on X-ray. This is inflammation in blood vessels in the skin called vasculitis. These are the antibodies. This is a picture of the antibodies that we see in the condition. And then this down here in bottom left is what's called a red cell cast. This is from urine, and this is showing inflammation that's been generated by a kidney that is really inflamed. There are red cells that pass through the kidney. They kind of clump together and form this cast. And so this is, people would die from this disease just 30, 40 years ago. And so we realized we could give them a medicine called cyclophosphamide. And now the mortality is extremely low. We have very good medicine for this. So that's my pictorial tour through rheumatology. And just to give you like a basic idea of some of the more common diseases that we treat, and why I think this is such an interesting career. Some more advice as you're thinking about a career path going forward. Your path may not be linear, as I said before, and that is totally okay. So, you know, life is going to throw curveballs at you, and it's just going to. And you know, you just got to roll with it. I think it's how you react to that that's more important. And if medicine is really your goal, you will definitely get there if that's what you want to do. And I think I learned that in my life. I never expected to not get into medical school on my first try. So that was definitely you know, a learning opportunity for me. Be open to new experiences. I never would have found rheumatology if I hadn't been open to that. And so if people are presenting you with opportunities, you know, keep an open mind. You never know what you're going to like or not like. And so just be open to trying new things. I think that it's really important that you really know yourself going in. It will help you find the specialty that best fits for you. And you'll have plenty of opportunities, you know, to do electives and figure that out. And you may go in like me, and most people do, going in thinking they're going to do one thing, and you'll change your mind. And almost everybody does. So my husband thought he was going to be a cardiologist, and he ended up being a geriatrician. And I thought I was going to do primary care, and I ended up being a rheumatologist. So, you know, that's why you go through the experience. And, you know, sometimes it takes you a while to figure it out. I mean, I've run into plenty of people who at least did residency and then said, you know what, I don't know. I know I want to specialize in something. I don't know what it is yet. So they went and worked as a hospitalist for several years until they figured it out. Nothing wrong with that. Or they just decided, you know what, I really like general medicine. I'm just going to do internal medicine. And that to me is a harder job. You know, you're trying to be an expert in everything. That's incredibly challenging to do internal medicine or whatever it is. So, you know, to not specialize. So you will find your path, undoubtedly. I don't think anyone ever said these words to me. Medicine requires personal sacrifice. I don't think anyone ever said that to me, so I really wanted to just say it to you. What does that mean? It means that there are going to be some birthdays and holidays and important things that you're not going to be at. And it feels really bad when you don't get home for what you want to get home for. Like, no one ever said this to me, and I just want you to hear it. But in the end, I still think it's incredibly rewarding. You know, there are sick people out there that need our help. And so you have to go into it for the right reasons, because I've seen people go into it for the wrong reasons. I have a very close person in my life who went into it for the wrong reasons, who got pressured really into going to medical school by family. Bad idea, right? You're just never going to be happy. And so you've got to go into it for you because you know it's something you want to do. And you've got to realize that this is not just a job, it's a career, and it really does require a lot of personal sacrifice. I'll say it again. And you know, if I had to do it all over again, I would. I'll be honest with you. I love it that much. And I know there's a lot of burnout, and I know, you know, that's been a topic that everyone's talking about. And I think it's good. I mean, we have to talk about it and we have to address it. And I think it's hard to think about going into medicine these days, but I think there's still so much that's rewarding about it. When you're in a room with a patient, trying to help them through their problems, and they're incredibly grateful, like that is a very rewarding and meaningful interaction that can be very sort of professionally and personally fulfilling. Along the way, there will be many, many people that help you achieve your goals in small ways and big ways. Don't forget to thank them. I think about all the people that helped me. You know, it's hard to think about how many there are, but just try to thank them along the way. And then when you get to where you need to be, there are going to be people that ask you to do things. Just remember that. Remember you had people that helped you, and try to pay it forward. That's what I try to do. You'll get busy. You'll have a million things on your plate, but people appreciate your help. So always try to remember that. Sorry, I don't want to be too preachy, but this is medicine, right? Like we pay it forward. Somebody helped me and I want to help the next generation. So I think we have to keep that in mind. I think that is my last slide. Yes, that is my last slide. So I wanted to leave time for questions. If you had any questions or discussion, or you know, anything about medicine or application process or whatever. I know the topic for tonight was broad, but I wanted to leave time. So thank you so much for your attention.
It looks like there's a question in the chat. I can read it off. Lay says, thank you for your presentation and advice. I have learned something about physiatrists,
Yes.
sorry, which also involve non-surgical interventions, including injection and ultrasound screening. Can you tell me more about the difference between rheumatologists and physiatrists, including the training path and focus?
Absolutely. So physiatrists do a PM&R residency, which I think is 5 years, and like 1 year intern year and 4 years residency. Don't quote me on that. I think that's true. Or maybe it's 4 years altogether. It's something like that. And they don't do the immunology part that we do. So they have kind of more of a physical medicine, sports medicine kind of focus. So they would be the people involved in like acute inpatient rehab, where they're focused. I mean, they do medicine, but they wouldn't be seeing people on an outpatient basis like I do and prescribing them medicines like methotrexate, Humira, prednisone, rituximab. They don't do anything with the immune system or immunosuppressing medications. And I see the second question there. I'll read that one out. So why do I think there's such a large gap between the amount of adult and pediatric rheumatologists? So this is an interesting question. You know, there aren't that many training programs for pediatric rheumatologists. And so when you don't have a lot of training programs, you know, you're kind of not going to churn out a lot of pediatric rheumatologists. The other issue is that pediatric rheumatologists actually make less than pediatricians. So there's a huge problem. You know, why would you do 3 years of additional training and then get paid less? You better really love that specialty, right? I mean, that's just reality. I hate to put it that way, but you know, there are a few people that are going to do that. So I think those are two problems. I also think, again, that it's a matter of exposure, right? So I don't know how many pediatric residents actually get exposed to pediatric rheumatology. So for a lot of programs, either internal medicine or pediatrics, rheumatology is not a mandatory elective in your residency. Some programs it is, but some it isn't. And so if you're never exposed to it, how are you going to know it's an option for you? So I think there are lots of different reasons, why people don't go into it. It's a shame too, because I mean, on the pediatric side, there's a lot we can do for kids. There are a lot of kids that get rheumatologic disease. Kids get arthritis and weird periodic fever syndromes and um, lupus and scleroderma. I mean, kids get a lot of the same things adults get, plus their own set of diseases, and there's a lot we can do for them. So it's a shame. I think, again, there have been lots of attempts at trying to recruit people into that field. There have been attempts at the national level at trying to reduce the amount of training necessary, like trying to combine training, residency, and fellowship to shorten it so that people can actually get through that training faster and maybe make that more appealing. But those attempts have not been successful.